So hello everyone and welcome to the second case of this case study series. So today we'll be discussing a very interesting case. So here we have a 50-year-old chronic alcoholic who presented to the emergency department with acute abdominal pain and bilious vomiting. He also gives a history of recurrent episodes of upper abdominal pain in the past. So suspecting a case of intestinal obstruction, abdominal X-ray was ordered, and this is the abdominal radiograph where we can see this over-distended stomach with air fluid levels, hence indicating gastric outlet obstruction or intestinal obstruction. And CCT abdomen was advised for further evaluation. So this is the CCT abdomen. I'm scrolling from cranial to caudal direction now, where we can see that the stomach has been decompressed now, and there is thickening of the wall of the duodenum, along with some fluid in the groove between the duodenum and the pancreas. The pancreas appears bulky. The head of the pancreas appears bulky with some cystic changes. There's some peripancreatic fat stranding and collection that is seen. On these coronal images of the contrast, again we can see that extensive fat stranding, mesenteric fat stranding, as well as thickening of the wall of the duodenum, second part of the duodenum, just surrounding the pancreas, along with bulky head of the pancreas and some cystic changes in the pancreas. So there is some inflammation in the head of the pancreas and the adjacent second part of the duodenum, the wall, along with some fluid collection in the pancreaticoduodenal groove, which indicates the diagnosis of groove pancreatitis. So paraduodenal pancreatitis or groove pancreatitis is an uncommon type of focal chronic pancreatitis. It's a type of chronic pancreatitis, that is recurrent episodes of pancreatitis will be present in the history, and it typically affects the groove between the head of the pancreas and the duodenum and the common bile duct. It is classified into two forms, pure and segmental form. The pure form exclusively affects the groove between the head of the pancreas and the duodenum, while the segmental form extends to involve the head despite a clear predominance in the groove. So this was actually a segmental form where the head was also inflamed and bulky with some cystic changes. The hallmark of the disease is the presence of scar tissue with fibrosis in the pancreaticoduodenal groove, or in the groove and the superior portion of the pancreatic head. The duodenum is always involved by the chronic inflammatory process, scar tissue in the wall leading to fibrosis and various levels of stenosis. So you have to keep this particular entity also in mind as a cause of intestinal obstruction, that is paraduodenal pancreatitis or groove pancreatitis.